Hello, everyone. Welcome to this CIN webinar on engaging providers in substance use disorder treatment. My name is Marie Hubbard, and I'm the project manager for CIN. For those of you that aren't familiar, CIN is a network of quality improvement leaders focused on innovation in healthcare. CIN is funded by the California Healthcare Foundation and administered by Health Force Center at UCSF. A few logistical pieces before we get started. Everybody is on mute. If you'd like to ask a question during the presentation, please use the raise your hand function or type into the comment box, and we will get to as many questions as we can within the hour. This webinar will be recorded, so please, at the end of this recording, please make sure to share it widely among your networks. I'm now going to introduce our speaker, Dr. Candy Stockton from Humboldt IPA, which is one of CIN's partner organizations. And I'll now hand it off to you, Dr. Stockton, to get us started.
Good morning. You can all hear me?
Yep.
All right. So the topic today is on how to engage your providers in your network to be willing to begin to treat patients with alcohol and opioid use disorder. And I understand that I'm not talking to many providers today, that I'm mostly talking to people from networks that are looking to start treatment within their organization. So with that said, I am going to give a brief overview of what medication-assisted treatment looks like. So I think it's important to understand some of the complexity of that and why some of your providers might be a little anxious or reluctant to jump right into treatment. So first, just a little background on why medication-assisted treatment is important. So every year in the United States, or last year in the United States, there are about 72,000 opioid-related deaths. There are also about 88,000 alcohol-related deaths annually. Nearly 7,000 people seek treatment for use or misuse of drugs in the emergency room every day. 10 to 20% of people that you see in primary care and hospital settings have a alcohol use disorder. Less than 10% of people with substance use disorders are able to obtain treatment annually. And this one is probably a big push for many of you. People with untreated alcohol use disorder use twice as much healthcare and cost twice as much as those people with alcohol use disorder who are treated, and healthcare costs for alcohol use disorder and substance use disorders in general in those patients decrease by about a third in the 3 years after engaging treatment. So that can be a significant improvement in both patient outcomes and cost outcomes for your organizations. So a little overview of alcohol use disorder. There are 3 FDA-approved medications for treating alcohol use disorder and 3 that are commonly used that are off-label or not. I won't go into great detail on those. And then when you're talking about opioid use disorder, there are opioid agonists, meaning things that do more or less the same thing to the brain receptors as your drugs of abuse do. So methadone, there's some significant limitations around that. It can only be prescribed for addiction through a licensed narcotic treatment program, although you can prescribe it for pain outside of that setting. And then the buprenorphine, with or without naloxone, can be prescribed in a regular doctor's office setting or provider office setting, but it does require a special waiver to be able to prescribe that for physicians. That's an 8-hour training course, and for physician assistants and nurse practitioners, it's actually a 24-hour training course that they have to complete prior to being able to prescribe these medications. There's also a medication that's an antagonist or an opioid blocker. It's naltrexone in a monthly injectable form. It doesn't have any special requirements in terms of becoming waivered or licensed to prescribe it, but it is logistically difficult and expensive. It's hard to get covered on many insurances and costs quite a bit for patients out of pocket, as well as having some difficulty around how your organization purchases and dispenses the medication. So again, not trying to really educate anybody about how to treat, but just to give you some idea of why this can be a little overwhelming for providers. Alcohol use disorder, there is no special regulation on treatment. There's no requirements before you can begin treating. But alcohol withdrawal is potentially fatal, so there are liability issues and ethical issues around treating if you're not comfortable and educated on that. Many of the patients who need detoxification will actually need hospitalization for that. There's lots of different medication choices. There's a question of whether you're just detoxing a patient or whether you're putting them on maintenance treatment. So overall, the treatment for this is a little confusing for providers. But there is fair access to community-based support treatments, things like AA and other community-based programs. For your opioid use disorders, again, you either have to be a licensed narcotic treatment program or have a Data 2000 waiver to be able to prescribe buprenorphine. So there are some regulatory hurdles. Opioid withdrawal is very unpleasant, but it's actually not physically dangerous for most patients. If you do get your waiver and start prescribing, you have to track how many patients you're prescribing for because there are patient limits depending on how long you've been treating patients. In your first year of treating, you're limited to 30 active patients. After your first year, you can apply for an extension to treat up to 100, and after 2 years or after a year of having an extension, you can actually apply to treat up to 275 patients. Prescribing for this is actually very simple. There's just variations on buprenorphine and naltrexone, depending on which brand you use, but it is heavily regulated by both the federal government and insurances. It does have broad coverage on Medi-Cal plans, so that is nice if you're working with that population. And there are very strong expectations for additional community-based therapy, which in some of your communities you may have limited access to. So that can be another barrier for physicians. So having said all that to kind of give you a background of what providers have to think about in terms of training to be able to provide treatment, the most common barriers that we see to providers being willing to prescribe medications actually don't have anything to do with any of those. If you poll providers, the most common concerns are they don't want those patients in their lobby or their office, their waiting room, being disruptive to other patients. They have, I guess you would call them philosophical concerns with the idea that if they were to offer treatment, it's just giving a drug addicted patient a different drug and there's not really any difference. Um, Past that, if they do go on and get their waiver, many providers feel that the online training doesn't really leave them prepared for knowing how to treat patients and makes it feel a little bit overwhelming. They don't want to be the only provider in their community doing treatment because they're worried that they'll be overwhelmed if they're the only one taking patients. And then they have questions about whether or not their patients actually have access to counseling services. And in the early models of treatment, there were really strong um, warnings against providing medication-only treatment to patients if you didn't have access to extensive support and counseling services. So those are the most common barriers that we see to providing treatment. Now, there's articles on surveys where providers are asked these questions across the country, and this holds true across the country, and on individual areas where we've looked, including in rural Northern California, which is where I'm most familiar with. We surveyed local providers, and we got essentially the same concerns from providers in our own local communities as well. So what do we do with those concerns? In Shasta County, we developed a kind of a multifaceted approach to trying to increase both the number of providers that were waivered, but also the number of providers who used their waiver to treat patients. In the counties where I currently work, we don't have any local methadone clinics, so methadone isn't really an option for most of those patients, and office-based treatment with buprenorphine is the only treatment that we have available right now. So how do you address, I don't want those people in my lobby or my office, or why would I just replace one drug with another? So these are really often emotional and stigma-based responses from providers. And to be perfectly honest, you're gonna have a hard time getting past a provider who says that up front. the approach that we found to dealing with that is identify providers who already know they're working with this patient population. So providers who are frustrated because they keep seeing the same patients back with abscesses over and over and over again from, spider bites, I think is what most of the patients say. Um, providers who already see these patients, um, or providers who have a special heart for these patients. They may be providers who have friends or family members who've struggled with addiction, who have a family history of this. They may be providers who, because of their experience working with special populations, HIV patients, hepatitis C, pregnant women, who really see the burden of this disease of addiction and are anxious to be able to provide something better than just an abstinence-based approach for these patients. So identify the providers within your network who already care about working with and providing for these patients. If you don't know them, you might be able to talk to your labor and delivery and OB teams, um, to your drug counselors locally or within your program, and maybe find them that way. So once you've identified your providers who are likely to be receptive to treatment, the next hurdle to cross is I did the online training, but I don't really feel prepared. I don't want to be the only provider doing this in my community. My patients don't have access to counseling services, or I don't know if they have access to counseling services. So what we did for this approach is we worked with ASAM to provide what they call the 4 and 4 training. So instead of having an 8-hour online training, we do a 4-hour in-person training. And then the providers either need to follow up with either 4 or 20 hours of online training after that, depending on whether they're MDs and DOs or NPs and PAs. Along with our in-person training, which we did the first half of the day, we had a couple of hours of networking at the end of that event. We had representatives from all of our local treatment communities come and speak with the providers. Everybody got about 5 to 10 minutes to tell the providers who were there where they were from, what their program did and offered, what insurances they took, and a single point of contact within the program so that the doctor could contact them easily if they had questions or needed to coordinate care with patients. We also, by doing an in-person training, allowed the doctors or the providers to see other providers in their community who were also getting waivered, so they knew they weren't the only ones. They could see other people were doing it. And it allowed them to ask questions about aspects of the training that they weren't clear on, and also to develop contacts with other people so that they could ask questions as they went through the course of treatment. So maybe I thought I understood the training today and I felt prepared to go out and do treatment, and then I got into the middle of treating a patient and I had a question about what I should do in that situation, and I wasn't quite sure what to do with that question. So this allowed us to connect all of the providers with other prescribers in the community who were prescribing, so that they had a friendly face that they could call and ask a question, or when they ran into them at local medical meetings, a way to network them with those providers and share knowledge. Um, Once providers get started, we find that there's a couple issues with providers early in treatment that they run across. One is that they feel unsupported. They're not sure what to do the first time they come across a difficult patient case. One of their patients gets pregnant, or they find out that they're also abusing methamphetamines, and maybe they're needing, they're running through more strips and they have questions about whether or not there might be diversion and how would they check for that. And there's also some anxiety among providers that maybe they're practicing differently than other substance use providers, and maybe they're at risk for being targeted by the DEA or having problems with the pharmacy because of their prescriptions. So we addressed these issues by holding a bi-monthly support dinner where we invited all of the prescribers who had been through the training with us, as well as any other community prescribers or other people who were interested in prescribing. We usually had between 10 and 20 attendees for that, and we provided dinner for them. And we started with a more formal educational format, discussing maybe reading an article in advance and doing it as a journal club. There's a way to do that through ASAM and actually get CME credit for that. But what we found after doing these for a few months was that the providers were really more interested in just talking about the challenges and the successes that they were having with treatment, asking what protocols and practices other programs were following, and just sharing that information. And that was very, very important for our providers in feeling comfortable expanding their programs and seeing more patients. We also found that those providers who were able to attend the annual ASAM or CSAM conference in San Francisco really increased their understanding of addiction and addiction treatment, and became progressively more comfortable with treating patients and as serving as a reference for their local programs. So ASAM, or I'm sorry, CSAM actually has a sub-branch, MRF, the Medical Education Research Foundation. I think I got that right. That funds scholarships for providers, both residents, but also post-residency providers who are wanting to come and learn more about addiction. You can apply for that scholarship annually, and there's a whole program that develops around that. So if you are wanting to send providers and your budget is sort of tight for conference attendance, that can be one way to get them there, because that conference is very, very helpful in developing providers' confidence around treatment. And then the last thing that we found was really important for long-term continued prescribing was a mentoring program. So we offered our conference attendees two options. The California Healthcare Foundation was kind enough to sponsor formal mentoring with a outside expert, and we passed out those flyers and made that available to people. And of the 18 or 19 people who attended our training, nobody was really that interested in the kind of formal expert mentoring. The other thing that we did, though, was myself and one of the other more experienced providers in town passed out our names and contact information to providers who were wanting to get started and to programs. And across the board, pretty much everybody took those. So we did find that mentoring with a local prescriber, and it was not formal, it was simple as call me if you have a question or a problem, was really useful for boosting confidence and helping people bridge that hurdle and get started on treatment. If they knew there was somebody they could call if they had a problem, it made starting a lot easier for them. I will tell you, if your mentors are worried about the volume involved, I think I got 6 calls over a course of 3 months, so it wasn't overwhelming. More commonly, I would run into people in the hall at the hospital or at meetings, the grocery store occasionally, and they'd say, "Oh, I've been meaning to ask you this question. What do I do if?" So it was not very burdensome on the people who did agree to be local mentors. Just a few options for mentoring if you don't have a local champion. So the PCSS, if your providers register with that website, and I've put the link here, they will assign a mentor with a regular check-in process for any providers who want that. If your site is participating in the Hub and Spoke program, you can file an online request through Strata. That's the State Targeted Resources Technical Assistance Program. Um, and that's through the AAAP, the American Academy of Addiction Psychiatry. And they will match you with a local or regional person who has expertise in the areas that you're looking for. It's not direct mentoring, but it serves the same purpose of having somebody that you can ask questions and for assistance, or by contacting your local hub, who may also be able to put you in contact with your local regional person. MRF, as I mentioned earlier, has scholarships for the annual CSAM conference. And they provide an extra educational track for providers while they're at the conference, as well as ongoing mentoring and education. We do monthly journal club webinars, and the link for that is on the screen as well. And then identifying regional champions. So if you have a provider who's sort of maybe interested, but really kind of on the edge, if you can find somebody in your area or in a similar setting who is practicing and treating patients already, getting to spend a day or two with that provider and watch treatment can be really eye-opening and philosophy changing for providers who are kind of on the fence about whether or not they want to start treatment. So with that, I completely forgot that I was supposed to pause occasionally and ask Marie if there were questions, but I'm ready to open up for questions now. And for those of you who want to reach me outside for resources that we use, I've got my email on the screen, and I'll just leave that up.
Yeah, so just as a reminder, everybody is on mute. So if you have a question, please put it into the chat, the group chat, and I can announce your question on your behalf. There's also the raise your hand function, and I'll attempt to open your phone line so you can ask yourself.
So I'll kill time while you're waiting for questions to see if there are any. We had 19 participants at our original training for this. Of those participants, I want to say that 14 went on and completed their waiver. 3 of them were residents who actually were just graduating from residency and left the area, so we couldn't track them. So we got good response from those, and of the 14, 10 of them went on and were prescribing for patients or increased the number of patients they were prescribing for if they had already started within the year that we followed them after that. We also had a really big uptake in prescribers through those providers at their site bringing additional people to our support meetings and kind of spreading training at their site once they've been through that process. I could talk about how we got the dinners funded if anyone is interested in that. So we had a couple of options for that. One is, again, you can do it through your local hub and spoke site. So they were willing to sponsor dinners for the providers if you feel comfortable with that. If a lot of your providers are not affiliated with the hub and spoke site or with your hub, they may not. So we also had some funding for that came through our local county opioid safety coalition, who one of their projects was to increase access to medication assisted therapy in their region, and so they were also willing to fund dinners for us. And we also had we developed towards the end, we actually liked the informal approach better, so we actually just had participants who rotated the location and actually either prepared or ordered dinner at their own homes.
Are there any questions for Dr. Stockton?
And we could potentially just let people go back and get some time for lunch today.
Yep, absolutely. So we will conclude the webinar for now, since it doesn't look like anybody has any questions, although I will be sending an email after the webinar with the recording, and I'll include Dr. Stockton's contact information for those of you that are interested in connecting with her directly about engaging providers in this work. So please feel free to share this recording widely within your networks. It will be posted on CIN's website. We also have our next webinar with Dr. Stockton on November 6th from 12 to 1 p.m., where she'll be talking about engaging patients in substance use disorder treatment, and we hope to see you all there. For those of you that haven't yet registered, that is also on our website at www.chcf.org/CIN. So thank you all for joining us, and we look forward to seeing you on future webinars.